Hi, this is Greg Stone from New York City. Welcome everybody to SIF Virtual. This is one in a series of webcasts that we've been doing, which have been extremely well received, and a lot of people are watching these on demand. So we hope you enjoy this session, which is going to be on revascularization of patients with complex coronary disease. We're going to break it down into two different parts: patients with left main disease, and then patients with multivessel disease with or without diabetes. And I've got a fantastic panel and group of speakers here today, including David Rizik from Arizona, Dean Kereiakes, Chris Piercecchi, Kendra Grubb, David Cox, and Shripal Bangalore. So let's get started, and we're going to start with, I'm going to give us a very quick overview of left main disease, and then we're going to see a representative case, and we'll talk about the specifics of the case and how to best apply evidence to the options for revascularization. These are my disclosures. I do work with a lot of companies, but I have no financial interest with any stent manufacturers. So a lot of what we know about the treatment of left main coronary disease really comes from the Syntax trial in the modern era. And this, of course, was a total of 1,800 patients that were randomized, but 705 of them were a stratified left main subset, so a true randomized trial within a randomized trial. And when we look at the overall 5-year outcomes of patients randomized to Taxus drug-eluting stents, first generation DS, versus coronary artery bypass graft surgery, the outcomes weren't that different. The primary endpoint was the quadruple endpoint of death, MI, stroke, or unplanned revascularization. And it tended to occur slightly more commonly in the PCI patients than the surgical patients, but not statistically significantly so. But we did learn that there was a big difference from this trial according to the underlying complexity of coronary artery disease. And patients with a lower intermediate Syntax scores had very similar outcomes with both PCI and CABG. In fact, if anything, mortality tended to be a little lower in this subgroup with PCI. But if you looked at the patients who had very complex coronary disease, the high Syntax scores, the outcomes were clearly better with surgery. So the question is, coronary bypass graft surgery is really the gold standard for treating all complex coronary disease. The Syntax trial suggested that patients with mild and moderate complexity disease may be sufficiently and adequately treated with PCI. And since Syntax, there had been a lot of changes in interventional cardiology with better stents, better procedures, image guidance, physiologic guidance, better pharmacotherapy, et cetera. But of course, there's been improvements with bypass surgery as well, with more of an emphasis on pan-arterial revascularization, screening for high stroke risk patients, et cetera. So with that in mind, we designed the Excel trial, which was the largest randomized trial to date in left main coronary disease. And with 1,905 patients, it's almost 3 times the size of Syntax. Specifically, we only took patients with a low and intermediate Syntax score, visually estimated, in whom there was equipoise at the clinical sites for revascularization either by surgery or PCI. And we used all best practices. This was an academically driven study that was designed by an equal number of cardiologists and cardiac surgeons. We used best-in-class Xience everolimus-eluting stents in the PCI arm with intravascular ultrasound imaging, strongly recommended in all cases. In the bypass surgery arm, the pan-arterial revascularization and all other best practices were recommended as well. And given the size of this study, it was the first trial that was ever actually powered for the triple endpoint of death, large MI, or stroke, recognizing that repeat revascularization is a lesser endpoint, not necessarily more important than atrial fibrillation, renal failure, et cetera. But everyone agreed, the surgeons and the interventionalists, that death, MI, and stroke, especially large MI, which was our definition, was worthy to prevent. And when you looked at the overall outcome at median 3 years, which was the primary endpoint, and then the final report at 5 years, you could see that there were overall approximately similar incidences of death, stroke, or myocardial infarction as a composite endpoint. 22% versus 19.2%, odds ratio of 1.19, not a statistically significant difference. But you could see that these curves overlapped. These are what's called non-proportional hazards. Early on, PCI was substantially safer than bypass surgery. Then there was a catch up because long-term, there were fewer events after bypass surgery than after PCI. In fact, we could break it down into 3 distinct periods. In the first month, you could see about a 40% reduction in major cardiac events with PCI compared to surgery. From month 1 to month 12, interestingly, what we usually consider the restenosis period, the event rates were almost identical. And then from 1 year to 5 years, there was a separation of the curves with fewer events after bypass surgery than after PCI. And the curves were diverging over time. If we look at a little more detail, you could see how different these procedures are. At 30 days, there was no difference in death. Very low rates of death now with both of these procedures, despite the fact that these were moderately complicated patients. 1% mortality, which is really excellent. Stroke tended to be less after PCI. The biggest difference, though, was myocardial infarctions. And it was really big myocardial infarctions that were reduced by about 40% in the peri-procedural period. These were ST segment elevation MIs. And the biggest difference was that there were fewer stent thromboses compared to actual graft occlusions. We agreed on another pre-specified definition between the surgeons and interventionalists of what are other major important adverse events to count within 30 days. And here's the ones that we had agreed on. And you can see in addition to the major ones, plus revascularization, there's major bleeding, transfusions, major arrhythmias requiring cardioversion or treatment, additional procedures, renal failure, sternal wound dehiscence, sepsis, et cetera, et cetera. And overall, these adverse events occurred in 12% of patients after PCI versus 44% of patients after CABG. So it wasn't surprising to anyone that PCI had a lower incidence of peri-procedural comorbidities and complications. But when we looked at 5 years, we saw a different picture. The top line of death, stroke, or MI you saw was not statistically significantly different. Now you can see on this slide, as dictated by the New England Journal, there's no p-values. And that's because after death, stroke, or MI, everything else is hypothesis generating and nothing else was corrected for multiple comparisons. And we looked at about 35 secondary endpoints. Nonetheless, we see some important differences. You could see that there was a slight excess of all-cause mortalities after PCI compared to CABG of 5 years. And 5 years was the first time the difference emerged. It's about 3% in 5 years. So it's about 0.6% per year. It's not a huge difference, but you can see that the confidence interval doesn't cross 0. Now, what drove that was not cardiovascular deaths. The rates of cardiovascular deaths were very similar between the two arms, and that's consistent with the fact that there was no significant difference in myocardial infarctions between the two arms. The biggest difference was in non-cardiovascular deaths, and these were adjudicated deaths due to definite sepsis that led to the mortalities, as well as cancers, usually occurring between 2 and 5 years after the procedure. Here's the different adjudicated causes of death, and as you can see, it's mostly infections and mostly malignancies. There tended to be less cardiovascular events, 2% fewer, that's stroke or TIAs after PCI compared to CABG. But conversely, there were 7% more ischemia-driven revascularizations after PCI compared to CABG. Now, these are 5-year differences, so all of these differences, even if some of them are rare, are relatively small. Now, when you look at all-cause death, of course, that's the endpoint that trumps all. And as we mentioned, not even Excel, as the largest study, wasn't powered for death. And again, there were multiple secondary endpoints. The question was it a biologically plausible difference given this being driven by late cancers and sepsis. So it's important to look at all the randomized trial evidence for low frequency events. And this is a recent meta-analysis that was published of the 5 randomized trials of DES versus bypass surgery. And what you can see is that at a mean 5.6-year follow-up time in these 4,612 randomized patients, there was no significant difference in all-cause mortality. And these are the curves that go out to 5 years from the 4 major trials. The 5th trial was a small 100-patient trial. These are the 4 major trials. And you can see that in some of the curves, the red line's a little bit above the blue line. In other curves, the blue line's a little above the red line. But there's really not much difference in mortality in any of these studies. And it's often said, well, what happens if we go longer? What if we go to 10 years? Because that's when surgery will continue to show its legs. And that's true in terms of myocardial infarction and revascularization. The longer you go after surgery, you do start to see those differences emerge. But we really haven't seen that for mortality. So we have 2 trials that are out now to 10 years. And here's the Syntax trial in 705 randomized patients. And you can see at 10 years, if anything, PCI had slightly lower mortality than CABG, but no statistically significant differences. You can note between 5 and 10 years, nothing's happening in the curves. The curves are parallel to each other. And similarly, here's the pre-combat trial, 600 randomized patients out to 10 years. And you can see, once again, the curves are essentially superimposable with nothing special happening between 5 and 10 years. So the bottom line is that when at least considering left main disease, which I do think is different than multivessel disease, and we'll talk about that in the discussion, it requires a heart team discussion to compare these 2 procedures because they're very, very different. I think PCI has early advantages in patients who can have both. It's less invasive. It has fewer periprocedural complications such as stroke, MI, AFib, bleeding, acute kidney injury. It's got lower 30-day rates of overall MACE and more rapid recovery with better early quality of life and earlier angina relief. But bypass surgery has late advantages. It's a more durable procedure. There's fewer adverse events beyond 1 year, particularly fewer myocardial infarctions and repeat revascularization procedures. Overall, if you look at both PCI and CABG, there's no significant major differences in long-term survival, overall composite death, MI, or stroke, or quality of life. So you get to, for the patients that can have both procedures, you get to about the same place, but you have a very different pathway to getting there, is how I interpret the data. And so some of the attributes of one procedure versus the other may be more important or less important to patients. And of course, you've got to consider each individual patient's specific clinical and anatomic circumstances that may balance these scales in favor of patients doing better with either PCI or CABG. So with that, I'm going to stop and I'm going to turn it over to Dean Kereiakes, and he's going to introduce a case for us of left main disease. And we're not going to, then he's going to stop before he shows us how the patient got treated, and we'll have an open discussion.
Thanks very much, Gregg. The challenge is that nobody told me to present the case, and then we're going to have a discussion. So you can't, the treatment is going to be there before you know it. I have 2 cases back to back. They're not new cases. In fact, these are not circus cases. These are what I consider to be bread and butter cases. Emphasis on a simple approach. And I think they illustrate specific issues in PCI left main equivalent disease. Issues like, do you use 1 or 2 stents? Is there disease in the side branch? How bad is it? How diffuse is it? And those are just the kind of things, the angle of the side branch. You can tell this is 3.5 years ago. This is a lady that is 66 at that time. She had hypertension, high cholesterol, class 4 angina, was admitted to a hospital north of Cincinnati with STT abnormalities and precordial leads. Her troponin was initially normal. She had an angiogram, was put in the ICU on IV nitro and fractionated heparin. Both the interventional cardiologist and a cardiac surgical consult recommended a lemograph to the LAD. Perfectly reasonable. I had just walked off the stage giving grand rounds at Cedars-Sinai for my friend and now partner, Tim Henry. I'm serious. I was in LA when the picture shows up on my phone. Can you do anything for this lady, or do you want to do anything for this lady? I happen to know the husband. And I had a stop image of this. This is the REO view. And it's very tight. You can see that usually flow rates in the LAD are faster than the circ, but this almost boxcars because it's got diminished flow. It's got a critical osteostenosis. You can't treat this without. In the old days, we used to do DCA. I've probably done DCA on a dozen of these, Gregg. But you know, now this you can't treat that without involving the left main. This is the spider view. There's mild calcification. I'm going to talk a little bit about imaging, and I think it is very important I image mainly for sizing. So at that point, I decided to take a single stent approach here. And I think single stent versus 2 stents is, if you can do it, is great. The reason for that is there was little or no side branch involvement. There's a right angle takeoff of the side branch, so it's very favorable for that. Nevertheless, I still double wire it. Pre-dilated, this is a 4/0-12 synergy. The proximal part of this was about 4 to 4.25 on IVUS. This is the 4/0 synergy. And for the most part, my workhorse stents, because they're side branch friendly, flexible and deliverable, are Synergy and Onyx, very frankly. Rewire the circumflex. So I'm not sure entirely why I left the first wire down and didn't rewire. Sometimes I'll do that so I can see where that wire is referenced to the carina, and I try to go at the carina. Something I learned from Thierry Lefebvre 20 years ago, before 911, is if you hook the stent at the carina, you'll displace more struts into the origin of the side branch. And that's what you're going to see at the end of this. It looks kind of like a mini pedal, so to speak. Those of you remember the first pedal side branch stent. And then I go full in here with a 4/0 and a 3/0 simultaneously at 14 to 16 atmospheres is what I usually do. And it's hard to beat. I think if you look as the dye clears, you can actually see the struts that are in the ostium of the circumflex, in the origin of the circumflex that have been displaced. Proof of the pudding is this lady's had normal stress echoes every year since then. It's 3 years out. A little different scenario.
Maybe before you go on, we could quickly discuss the case.
Yeah, I think that's a great idea.
So was there involvement of that short left main? Did you image it baseline, or was it really a
IVUS only, not OCT at the time? No, the left main was actually, there was plaque there, but there was absolutely no significant obstruction.
Okay, so it was just an osteal LAD lesion. So it was a Medina 010.
I'd say that's correct.
Okay. So, well, let me ask my 2 surgical colleagues, both Kendra and Chris, is this a reasonable approach for this patient? Would you have considered a single mammary to the LAD? And how would you have had that discussion with the patient?
I'll let Chris answer first, and then I'll follow him.
So thank you, Kendra. How old was the patient?
66 at that time.
66. I think it is a reasonable approach. I think it boils down to the conversation with the patient and the heart team. The younger they are, I think I would lean more towards surgery. She's sort of in the middle. But I think ultimately I would preferably do surgery. But if the patient was less excited about that approach and the heart team agreed, and obviously cardiology felt comfortable doing that, then I think that's very reasonable to do to stent.
And would you offer the patient a mid-cab specifically, only if they asked, or no, you still think open sternotomy is the way to go?
I would do open sternotomy, and I would,
Kendra?
So I think it's an interesting question. And actually, David put me on the spot on the stage right after the Excel trial was released and asked me, what do I think of this? And I have no problem with left main stents. And I certainly have no problem with proximal LAD stents. But some of Chris's points were really important. What's the age of the patient? What are the other comorbidities of the patient? And what is the expectation? As Dr. Kereiakes presented this, he said, if you can do it. And I think that's a really important thing. Not all of these anatomies are the same. As you can see, there was a gorgeous distal target for bypass. And so if you're talking about who can give you the best result, I think it could be either treated with PCI, as done here, or with bypass. Emory is known for robotic limited LADs. And so that might be a great approach to this, a mid-cab as you suggested, or a robotic limited LAD. There are certainly some other options, or a traditional sternotomy and bypass the way that Chris described. There are a lot of options here, and I think the important thing is the heart team. Who is the patient? What are their comorbidities? Can the operator doing the operation, whether it be open or PCI, achieve an excellent result? That's the most important part.
So that's terrific answer. I agree entirely. So let me go to Dave Cox and then Dave Rizik. You know, we always discuss single vessel disease. The same way we think complex coronary disease is really the province of the surgeon, we sometimes think that single vessel disease is the province of the interventionalist. And that may not always be the case depending on its complexity. So there's nothing that I've seen that gives you the same long-term patency results as a mammary artery to the left internal mammary artery to the LAD. So Dave, what do we think though about this focal lesion, large vessel, even though it's osteal? How do you think the long-term results in those late events will be with treatment of this lesion with a good drug-eluting stent versus a LEMA?
I would think they would be very low. I guess the questions that arise in my mind, do we have to visualize how big the internal mammary is on our diagnostic cath? The second question I'd be is, you know, how long do we have to keep DAP going? It seems like we're doing DAP less and less. So it seems to be, at least in my mind, driven by, is the operator using IVUS more and more, whether it's a DAP DS or any other study, we seem to find that IVUS and these osteal LADs and left mains absolutely critical to predict good long-term outcome. So I guess my question, Gregg, this is an osteal LAD. I'm not too sure in my lab they would have gotten a surgical consult. So it's a little different from, you know, whether or not you should ask the surgeon advice about left main.
Yeah, and I was going to go there to Dave Rizik. So this patient wouldn't have been in Excel. We did have patients in Excel that were left main equivalent disease, which would have been a significant osteal LAD and osteal circ with a normal left main. That was about 5% of the patients, but we didn't have any isolated, 0-1-0s. So I will say that I still see interventionalists, they're not all comfortable dealing with osteal LAD lesions, especially when they've got to cross over to the left main. So Dave Rizik, in your lab, would you have, if this was an ad hoc procedure, would you have taken this patient off the table? Would you have had the discussion with the patient about the options of bypass surgery versus PCI, or would you have just gone on and fixed this if this is what you're doing?
Yeah, Gregg, I think that's the perfect question. I think in my lab, the answer is we absolutely would not have taken the patient off the table. We would have treated this like single vessel. I think there is no way this would be done without intravascular ultrasound or OCT. I think imaging, if we're going to achieve the type of durability, you said LEMAs are very durable. If we are going to achieve the type of durability that we get with LEMAs, imaging is essential. And that stated, 10 miles away from where we are at, I would bet 90% of the interventional cardiologists wouldn't have touched this. I think there are places around the country where people really don't yet feel comfortable with this. And in the state of Arizona, I think there's a great dichotomy. I can think of a lot of centers here where this would have been surgical disease from the very beginning. In our lab, though, patient wouldn't have been taken off the table. This would have been intravascular ultrasound guided single crossover stenting, just like Dean did.
All right, so Dean, show us your second case, and I'll presume this is going to be a real left main.
This is a very different case. This is also about 2 years old, coming up on 2 years. This is an 84-year-old guy who's got class 3-4 angina, multiple comorbidities. His EF is about 40% with posterolateral hypokinesia, as you'll see. He's got 6 sinus syndrome, dual chamber pacemaker, and he's paced. His troponin was normal. This was actually brought up in one of our cath conferences. Now, this on IVUS, this is a dominant circ. You can see that. We'll go back and look at it, and you'll see it in the spider view coming up. The density of contrast, the distal left main origin of the LAD is diminished for a reason. By IVUS, it's about 50% or more stenose. So this really is, I would say, probably more like a 111, Greg.
Okay.
This is the, believe it or not, there are interventionists who are really still intimidated by that anatomy. I just happened to watch Ajay Kurtani give some of his sky lectures recently. And frankly, you saw a balloon pump in this guy. And some people would say, why did you put a balloon pump in this guy? Well, oftentimes I don't. I'd say the majority of my left mains I do without mechanical support, so they don't need it. When I think they need some mechanical support, the majority are probably given this, which is a balloon pump. It really works. And I think it's very effective in repaying the flow debt, particularly in people like this. The problem with this is when you go up in a balloon, and once you see the pressure fall, you sometimes see the QRS, QT interval widen out, and the pressure keeps falling. And that's why I think in this randomized trial of BCIS that Ajay showed the other day at SCI meeting, you have a reduction in prolonged hypotension, VTVF, and CPR. Because flow is totally pressure dependent. When you diastolically augment the patient, you can really facilitate the recovery very quickly. And so I think a balloon pump, which takes a single 8 French angioseal or a single perclose, really a no-brainer, is very easy, very quick, much less traumatic or associated with other issues than an Impeller. When do you use an Impeller? I think we have, particularly our younger guys, really have like an emotional attachment to Impeller. And I think in some ways, the hospital reimbursement is clearly better, but this is one study that suggests the extent of revascularization. You know, personally, I look at left ventricular dysfunction. It's got to be under 35%. The extent of revascularization. Am I going to use an ablative technology? And lastly, what's the LVDP, the physiology? Does this patient really need LV decompression, which is the main reason I would use an Impeller. And so the patients are much sicker than this guy if I'm going to do it. I also point out that, frankly, if you look at what's being done left main, if you believe this, and Greg, you're very familiar with this paper. This was from the JAMA Cardiology by Valley, where you look at the bifurcations and it compares clinical practice with clinical trial, which is Excel. And if you can see in Excel, 81% of the left main targets were bifurcated. That's exactly what we see in clinical practice, 8 out of 10. But 55% of the left main targets in NCDR, remarkably, are osteal mid-shaft. I mean, that's widely discrepant in general, anatomic complexity. IVUS was not used, imaging not used in 60% of the left mains that were done in the US as recorded in NCDR. And despite what appears to be a differential in anatomic complexity here, a mechanical cardiac support is 4 or 5 times higher in the NCDR than Excel. Very interesting. 14% of that 25% were balloon pumps. The strategy I chose was not a DK crush, and I'm going to talk about that briefly because I think there's a lot of very experienced interventionists that are not using DK crush as a go-to strategy right now. This is a definitive balloon for the circ. I'll pot the origin of this, the proximal end of this stent, recross into the LAD. This is going to be a culotte with that angle takeoff. This is a kissing balloon. So many of the steps are very similar to DK crush. Then placement of a 3-5-16 synergy, pot the proximal end of this with a 4-0 balloon, recross into the circ. And instead of using a 4-0 and a 3-0, I used a 3-5 and a 3-0 simultaneously at a high pressure inflation and got this result. The balloon came out. This guy still followed. It's 2 years out, doing extremely well. But the case, pretty simple and pretty quick.
So Dean, this patient, really, there were no other lesions really. The right coronary was okay.
Right coronary is non-dominant, doesn't feed left ventricular
Okay. All right, so it was a left dominant system, but it was really primarily a Medina 111. That's what the disease was.
Simple.
Okay.
Some people, would you have used DK Crush?
I personally would have, but we can talk about that. Go ahead.
Yeah. Well, you know, when you look for what are current guidelines, you got to look outside the US because AHA, ACC, it just takes a little longer than the Europeans. And this is a 2A recommendation, which I think is strong for imaging, and I agree with that. It's shocking how infrequent it's done in the US, but this is a 2B. I mean, this is the lowest recommendation you actually do for a patient for DK Crush. These are just what's new, which includes the DK Crush, was new in the 2018 ESC guidelines. And based on these data, Gregg knows this as well as anybody in the world. These are the 2 randomized trials with a 3-year follow-up of both trials, suggesting that DK Crush compared to either provisional or culotte in a randomized fashion reduces these adverse events out to 3 years. I won't beleaguer the stratification of these patients into either complex or simple based on the presence and severity of disease in the side branch and other modifiers, which can shift somebody from simple to complex. And what I'd like to get to, these are the multiple steps, probably the best single diagram that I've seen for, you know, outlining the steps of a DK Crush technique. And I want to leave you with 2 thoughts. One is target lesion failure, and you'll see thrombotic. If you use 2 stents in a left main, and Gregg, this is going to probably provoke some conversation here. There are data. This is a pooled analysis of 5 registries that you're familiar with, that if you stop DAP within a year, that you'll have an increase in adverse events compared to 1 stent, and that extending DAP beyond 1 year mitigates the hazard of 2 stents compared to 1, as you can see. Same thing for thrombotic adverse cardiovascular events. So somebody mentioned earlier, what about DAP duration? If I do complex left main, I think that's perfectly consistent with the Justino-Dangus, algorithm for predicting complex PCI. If I do 2 stents in the left main, I'm going to recommend DAP for at least a year. So I asked 2 of our friends. I was giving a talk for Robert Riley's course here in Cincinnati. And I asked him on that date, and I asked him if I could quote him about DK Crush. Are you using it? Antonio Colombo, Paul Tierstein. With new stents, TAP is best, quick and minimal deformation of the side branch stent. And Paul waxes on, as Paul does. The TAP procedure is just so much quicker, less stent overlap, find it more appealing. Suspect new stents just so good, it's hard to distinguish outcomes between the techniques. You know, I completely agree with these things. And we will do it on occasion, but it's not, I'd say more often than not using DK Crush. And so do they. So now that we've poked the bear, let's talk about it.
Okay, no, that's great. Okay, so well, before we get to the technique, let's talk about PCI versus surgery in a case like this. Again, still not a severely complex case. A Medina 111 lesion like this is actually, believe it or not, kind of on the borderline. I think it gets you like 24 points. So it's on the borderline of a low risk to intermediate risk syntax score. And as you pointed out, about 80% of the patients in Excel had distal left main disease with at least a 50% bifurcation disease, with at least a 50% stenosis in both the osteal LAD and osteal circ. So this is a typical Excel patient. So I guess why don't we start with the interventionalist, and then this time we'll go to the surgeon. So let me go to David Cox. David, if now you're doing an ad hoc cath plus minus PCI, you weren't expecting left main disease, and now you see this anatomy, okay? So it's basically no severe disease anywhere else in the LAD or the circ, but just a definite Medina 111 bifurcation. Do you take this patient off the table, or do you go ahead and fix it?
Now, this one I'm definitely taking off the table. If it was an osteolar body, we can have that discussion later. But I think this one comes off. We have some discussion about can they truly take DAPT, and then I'd like to get a surgical opinion rather than surgery when I ask my surgical colleagues. Dean, I think the reason the NCDR data is so low for bifurcations is exactly that reason. Remember, to get into the NCDR, you have to have a PCI done. So all those patients that are taken off the table here and go on to surgery are not going to get into the NCDR PCI database.
Yeah, I think that's Dean's point, that people, the average interventionalist is not yet comfortable doing disc bifurcation disease. It's not that it doesn't exist. I mean, it was 80% of even the low and intermediate syntax score patients that we randomized. So it's clearly, and that's what most large studies and surgical studies have found, 75 to 80%. So it's just that interventionalists aren't yet that comfortable doing it. So let me continue with you, Dave Cox. So you take the patient off the table. How do you have the heart team discussion? Do you talk to your surgeon first? And if the surgeon agrees, yes, I could do this case, do you defer to the surgeon? Do you go to the patient to get the patient's opinion? And if you do that, do you go with the surgeon, or do you, like both the interventionalist and the surgeon, go separately to speak to the patient?
Yeah, I think it's different with different surgeons and at different institutions. I think the optimal case is that you talk with the patient yourself, then you talk with the surgeon yourself, and then we have a discussion afterwards. I think, unfortunately, and I'd love to hear what Chris and Kendra say, when you ask for a surgical consult, you seem to get surgery in a lot of places.
Okay, so Dave, Rizik, and then we'll go to Chris and Kendra. So Dave, you've now just found this unexpected left main lesion, no other significant disease. Do you take the patient off the table? And if so, how do you do the heart team approach?
Right. So 4 points I was thinking of as Dean was presenting this on the evolution of PCI left main. First, patient comes off the table, and very often our surgeon and the interventional cardiologist go in and talk to the patient together. Something we've tried, it seems to work very nicely. The other 3 evolutionary points are definitely image-guided PCI if it comes to that. We've gotten away in cases like this. I think if you look 5 years ago, this was a left main intervention, and it had to be, we had to use MCS. We've probably evolved away from doing that. And in terms of some of the other evolutionary processes, I think in 2020, as great a result as Dean got with this, I think in 2020 we've evolved to DK crush being the default choice, mostly because in both main and left main and main and non-left main bifurcations, it has been compared to culotte, it's been compared to provisional, and DK crush fares very well in both main and non-left main bifurcations.
So great. So I'll come back to the technique. I still think even the bigger decision, if you're a skilled interventionalist, the biggest decision though is it the right thing to do? That is an interventional approach versus a surgical approach. So before I go to my surgical colleagues, I'll tell you 2 interesting findings from Excel relevant to this patient. The patient had an ejection fraction of 40%. And I can tell you that, we didn't have many patients in Excel that had ejection fractions below 30%, but we did have a fair number that were between 40 and 50%. And we didn't see any difference in outcomes, short-term or long-term, in terms of relative outcomes based on that level of ejection fraction. But similarly, another interesting aspect of this patient was that the patient had COPD. Now, I'm presuming, Dean, that the patient, it wasn't end-stage COPD. The patient wasn't on 24-hour-a-day oxygen or oral steroids. But let's say the patient had moderate COPD. We had about 20% of the patients in Excel had moderate COPD. The only ones we excluded were those, again, on 24-hour oxygen and oral steroids. And interestingly, there was no difference in the relative outcomes of PCI versus surgery in any of the major outcomes for COPD versus no COPD. So those patients did just fine with surgery, as long as it was only moderate COPD. The mortality and the outcomes were in general worse in the COPD patients, but it was equivalently worse after both PCI and CABG. It didn't necessarily favor PCI just because they had moderate COPD. So with those in mind, let me go to, how about Kendra and then to Chris. So Kendra, in your institution, are these patients always taken off the table to have a discussion with you? Or do you think they're sometimes actually done? They are done with a PCI approach without having a full heart team discussion? And how do you do a heart team discussion? And what would you recommend for this patient? Let's say I'm the patient. What would you tell me about, maybe not trying to convince me to have surgery, but what would you tell me about the attributes of surgery in this patient compared to PCI?
Sure. Well, as a surgeon, I try never to use the words never and also always. And there is no always or never in our heart team. Certainly, sometimes these patients are treated right there on the table when the lesions are found. I think that the majority of the time, however, they are being taken off the table to discuss their options. And this particular patient, given his COPD, given his age, he would be one who was more likely to fall into just being stented. But let's say he was you, Gregg, and wasn't 84 years old. I think that's a classic example of the patient deserves the opportunity to at least hear all the treatment options. And we often have this conversation. We are not having the conversation together, the interventionalist and the surgeon, but I will oftentimes come to the lab and review the images with the interventionist. We will kind of come up with our idea of what we think is best. And then when I go to approach that patient, I present it that way. I think that it's really important that patients understand what it means for bypass surgery, that we're not treating the lesions, that we're bypassing that area. And so I explain the procedure to them, and then the risks and benefits based on their STS predictive risk of mortality. So I calculate it for every single patient, and we literally go through the numbers of what is your risk of death, stroke, heart attack, blood transfusion, how many days are you going to be in the hospital, what's your downtime, and help the patient decide what's best. Certainly, the younger the patient, the more complex the disease, the more likely I'm going to really push for surgery. But in this case, if the operator has the ability to do the case, and we're not talking complex rota Impeller assisted, then I think it's perfectly appropriate for that patient to be treated with PCI.
Great. And Chris, same question, same considerations for you.
Yeah, so Kendra pretty much said it all. I'll comment on the heart team approach. I'm a strong proponent of that, and I think that it's very important in these cases to have that conversation with cardiology. My experience here in Scottsdale, oftentimes I go to the cath lab and I speak to them one-on-one. We look at the imaging, and I have often visited the patient with the cardiologist. Of course, having had a discussion to the side prior to that. But I think, again, in the younger patients who are ideal surgical candidates, you know, when you're dealing with left main, my instinct is strongly leads me towards surgery. But of course, in that conversation with the heart team, you know, we may find some other reason why we would tend to go towards intervention. And of course, if the patient is strongly opposed to surgery, I'm all for that. I think completely reasonable to do that. But I think that the interaction between surgery and cardiology is the most significant part here. And fortunately, where we are with our lab, with Dr. Rizik, we have a strong lab. So that happens a lot.
Well, that's terrific. So let's, in our last few minutes here, let's talk a little about the technique. You know, these quotes from two of my friends are staring me at the face. You know, the DK crush technique, which is the only specific technique that has any sort of a recommendation in any guidelines, was, you know, really based on those two trials that Dean showed. And those were two trials that were run at many sites, but in China. They were true left main distal bifurcation lesions. One was against provisional, one was against culotte. And in both cases, DK crush had superior outcomes, particularly in the complex lesions, although the relative improvement was similar even in the more simple lesions, as long as they were true bifurcation lesions. For non-true lesions, then provisional is still clearly the way to go. But if you need a two-stent approach, that's what that those trials would suggest. The criticisms, of course, is that it's a more complex procedure. They were done with good contemporary stents, especially DK Crush 4, but they haven't been replicated outside of China. They haven't been in a good Western European study or a U.S. study, and I'm not going to say that's I'm not going to say that's any sort of international bias, but I still think that people do like to see studies replicated in their own geography before they get really comfortable with them. And regarding TAP, my feeling is that TAP, works pretty well when you've got short focal lesions and when the circ comes off at about a 90 or 80 degree angle. When you've got a 30-degree angle, the TAP is probably not the best approach necessarily. It's often not that uncommon to miss the ostium, or you're turning into a mini crush or something like that. And we just don't know. We just don't have that data. So, for those reasons, with an image guidance approach, I certainly don't mind spending 15 more minutes on a left main. There's nothing more important we do in the cath lab suite for coronary disease than left main interventions, maybe other than STEMIs. And I don't mind spending 15 more minutes to do a DK crush because that's where the evidence base is. So we heard a little from Dave Cox in that regard. So David Rizik, what do you think of the different techniques? How strong do you think the evidence is for one versus the other versus the practical considerations, get in and get out? What other studies would you like to see?
I think that I think you hit on all the high points. I think it's what you do well and what you're comfortable with. I think I agree with you. The slam on the crush, on the DK crush, is a lot of people can't remember the steps. That was a point that was made at Sky last year while we were doing a DK crush, is that people can't remember the steps. And if you're meticulous about a tap or a culotte, and you're meticulous with your imaging, doing that technique, and you're doing your final kiss and whatnot, I think those probably, in our experience, they're probably just as good. And I agree with you. I would like to see the studies that were performed in China reproduced, because we all do want those things reproduced. Gregg, I do have a question for you. I mentioned this idea of using mechanical circulatory support. What do you and the other interventionalists on the panel think of that? My own personal opinion is, with reduced EF or patients with heart failure, I think we should use it, selectively and without apologizing. A few years ago, any left main, irrespective of ejection fraction, et cetera, we were using mechanical support. How has the use evolved in your practice, Gregg, and in other practices?
Well, I think it's an evolving topic. I think when you need mechanical circulatory support to get the patient through the procedure, especially so you can have a more prolonged procedure and do a good complete revascularization as to just a partial job, then there's no replacement for it. And if you've got a patient with an ejection fraction of 25 or 30% and severe multivessel disease and left main disease, and the patient's been turned down for surgery, and you're going to have to put in 5 or 6 stents and do an extensive revascularization, you're going to need support. And in that kind of a case, then I would favor, in most of the cases, Impeller support. Especially with the CP device, you just get tremendous forward cardiac output, and short of 100% total cardiovascular collapse, the patient's going to get through the procedure without a whisper. The downside, of course, of all mechanical support procedures, whether you go that route, whether you go tandem heart, whether you go intra-aortic balloon counterpulsation, in the less severe cases, maybe Dean's kind of case with an ejection fraction of 40%, of course, is bleeding and vascular complications. And you could see even in the BESIS-1 trial that bleeding tended to be twice as common. Major, I think it was to me, major and minor bleeding was twice as common in the balloon pump arm. And that was with an 8-French sheath. So it'll be even greater with larger sheaths with Impeller, although the Impeller is coming down in size, and now there's expandable E-sheaths, so that's going to decrease complications, but it'll never eliminate them. So we've got to learn how to really pick which cases in which support is necessary, and in fact may let you get not only better acute but long-term outcomes because of doing more complete revascularization versus those in which you might think it's only nice to have. In Excel, as you saw, mechanical circulatory support was required in only 5% of cases, or was used in only 5% of cases. And that was despite having about 20% of the patients with an ejection fraction in the 40s, with a 1% 30-day mortality. So in most patients, it's probably not going to be necessary. But in patients, again, with very complex disease, with the three things that I look for hemodynamically are the ejection fraction, the pulmonary capillary wedge pressure. If you're really worried, then do a right heart cath, and the baseline blood pressure. Baseline blood pressure is really helpful. If you've got somebody that's got a baseline blood pressure of 95 to 100 millimeters of mercury and an EF of 35%, that's very different than a baseline blood pressure of 135 millimeters of mercury and an ejection fraction of 30 or 35%. So those three factors kind of tilt me towards wanting mechanical circulatory support. And again, the more severe the hemodynamic disturbance, then I go to stronger and stronger support. Maybe we can hear quickly from, I think Dean expressed his views. How about Dave Cox, your views on when to use mechanical circulatory support and then the choice between the different alternatives?
It's kind of interesting. I'm a big blood pressure fan as well. If you have blood pressure 130, probably don't need it. If you have blood pressure of 90 to 100, you kind of want that safety. The point I'll make is that I think MCS has changed a lot. We now do pre-close in the great majority of these cases, Gregg. So the bleeding complications we saw in BCIS wasn't with the pre-close approach with the intra-aortic balloon pump. So to be honest with you, I think we use it less, but we know better when to use it. How's that?
So I guess I'll close with one last statement, and that is that Abiomed has committed and will be starting by the end of the year or at the latest first quarter a very large-scale randomized trial of protected PCI in high-risk patients. That is protected with Impeller CP in most patients versus standard of care in the control arm. So I think this will take basically what was done in PROTECT 2, but it'll be much larger. It'll take it into the contemporary era and hopefully give us a definitive answer on is the bleeding and vascular complications, how can we minimize those with the techniques that Dave was talking about and others, and you know, whatever complications we get, are they worth it in terms of truly long-term outcomes? Can we reduce mortality, myocardial infarction, repeat revascularization, heart failure? Can we get better LV function recovery by doing a more complete revascularization in truly complex coronary disease in patients with depressed left ventricular ejection fraction? So we were going to talk about multi-vessel disease, but we have such an amazing panel and the cases were so great that we spent an hour talking about left main disease. So I think, Dave, if it's okay for you, we'll have a second session like this in the near future for multi-vessel disease. And at that time, we'll have Shripal present his lecture and have Dean come back and present his other cases and hopefully have the same panelists. And because there, I think, if anything, will be a richer discussion as to how to choose between PCI and surgery.
That's great, Gregg. Well, thank you, Gregg, for moderating this. And I want to thank all of our panelists and thank you for joining us for SIF Virtual.